Good afternoon, or in some cases in the West, good morning. It is an honor and privilege for me to introduce our speakers today, who have helped establish a model that I'm very excited about and would like to see translated as well in other parts of America, Europe, Canada, whatever. So our speakers today are Dr. Nicole Birge, who is an assistant professor of pediatrics, University of Nebraska, practicing at Omaha Children's. She is the director of the newborn intensive care unit there, and she's a member of the Division of Neonatology and has really made a mark for herself in the last few years with scholarship surrounding the care of kids with trisomy 18 and 13. Our co-speaker is Lois Starr, a fellow geneticist like myself, who known for a number of years now. Lois is an associate professor of pediatrics, also at University of Nebraska, and she is the program director of the fellowship training program, always a daunting position to have, but she has a very deep interest in education of fellows, medical students, and residents, and also in the care of individuals with rare diseases. So I welcome Nicole and Lois today from Omaha, and I'll turn it over to Nicole.
Thanks, Dr. Carey, and everyone who is able to join us. We're going to talk about the model that we have at Children's about our approach to care of children with trisomy 13 and 18. Part of this will be data review from other programs and facilities that offer care to children. Some of it will be information that we're going to review from Omaha, and then we'll sum it up at the very end, of course, with some photos of cute babies, because that's what I like to do best. So hopefully by the end of this, we'll be able to better understand both the complex and individual care needs of children with trisomy 13 and 18, as well as understand the role of interdisciplinary care with those patients. As Dr. Carey stated, we are located in Omaha at the Children's Hospital and Medical Center in association with the University of Nebraska Medical Center. We have a team whose name kind of changes depending on what we try to make it into an acronym, but it never quite works out. But we call ourselves the Interdisciplinary Trisomy Translational Program, which in and of itself is a mouthful. But really what we try to do is to individualize the care and services we provide to patients with trisomy 13 and 18. And we do that by having a very structured team that reviews referrals, both from families who are born in Omaha or the surrounding area, as well as families who seek our input from outside of the Omaha area. So standing team members as a part of this team include cardiology, a CT surgeon, someone from our pulmonary hypertension team, a neonatologist, which is me, a cardiac intensivist, and then we also incorporate our palliative care, social workers, and a care coordinator who helps organize us. We meet weekly on Tuesdays to do a thorough review of medical issues, look over labs, we look over echoes, we review cath data if that's available, and then we also do a fairly formal and in-depth interview and assessment with our social workers and palliative care team with a family to try to better understand their reasons for referral and how we can best support them. I have outlined here kind of the process that we go through when we are reviewing a patient to determine if it would be reasonable to bring them to Omaha for further intervention. And it all starts with our trisomy coordinator, Kelly, who does a fantastic job of gathering information from patients' medical records. Sometimes families self-refer to our program, and other times we get referrals from other physicians or other hospitals. And Kelly does a great job of bringing all that information together. And then we present it, like I said, at our weekly meeting. Some babies may have some conditions that make their very high risk for undergoing a surgical procedure. And in that instance, they would be deemed not a candidate, and the referral process ends at that point. However, there are plenty of other babies who we think would be great candidates for surgical intervention. And that's when we bring in our social work team as well as our palliative care team. We have phone calls and conversations both with the family directly, but then also with with the community or local social worker that the family is working with to try to help determine what needs a family will have to make a successful transition to Omaha. And if we think that we can support them here, both medically and socially, then they're presented for our larger group conference with lots of cardiologists and multiple cardiac surgeons and intensivists. And after we go through this process of everyone agreeing that this is a patient who should come to Omaha, we then bring them here for surgery to Omaha. The process is very similar for patients who are born here, and so they don't necessarily need to be relocated or transferred, but making sure, like we would with any other patient without a genetic diagnosis, that the cardiac intervention that is proposed will benefit the patient and offer the least amount of risk. And so we try to navigate that very similarly, regardless of the patient's underlying genetic diagnosis. I wanted to talk a little bit first before getting into some of the medical stuff about why we incorporate our social work and palliative care team early on in this process. And a lot of the domains I have listed here are lessons that we have learned along the way as we bring families to Omaha for surgical intervention, about questions that we need to ask and resources that we need to make sure we have available as families move. So for example, we have had a family become homeless during their stay in Omaha. And so we need to make sure that they have stable living before they transfer here, as well as stable housing before they transfer back home, to make sure that the patients that we care for have a place that they can go to that will help support them after their stay with us in Omaha. Similarly, things like transportation and making sure, whether it's through a family car or public transportation or getting a ride with a friend, that families have access to get to the hospital for regular appointments or for emergent needs, and that they have something that can accommodate extra medical equipment that babies with trisomy 13 and 18 may actually have. And so I don't want to go through the entire list, but just to know that we try to ask families all of these questions and get as much information as we can before they come to Omaha, to make sure, like I said, that we have the right resources in place to make their transition back home as successful as possible. So the goal of our interdisciplinary meetings are to not only come up with a medical plan of care for the baby, but to also open up communication between the family that is seeking intervention here and the referral center if they're outside of Omaha. Many families have been denied surgical intervention based on the genetic diagnosis, and so have lost a lot of trust between their local healthcare teams. And so we work really hard to try to reestablish that trust, knowing that this baby, after their discharge from Omaha, will be going back to the same care team. And so how can we get the care team and the family re-engaged and open those lines of communications? We will do that. We've done virtually by WebEx or Zoom meetings or by phone with the family and the home institution. So it's like a three-way phone call where we make sure we're all on the same page, making sure that the resources we think the baby needs can be provided at home, and to make sure any loose ends that need to be addressed in Omaha prior to transfer, that we get that done. Our program has grown in the number of referrals over the last couple of years. Most closely linked with a talk that our cardiac surgeon gave a couple years ago at this very conference. I think that was in 2018 or 2019. And as you can see, our referrals for cardiac intervention specifically have increased significantly over the last couple of years. And most recently in 2020, we had over 70 referrals, and the vast majority of those are for cardiac reasons. And we're off to a brisk start already in 2021. So how do babies get to Omaha? Well, sometimes it's a postnatal referral where, like I said earlier, either the family or care team reaches out to us to see, get our opinion to see if we would offer surgical intervention or to transfer here for that specific intervention. And that review occurs with our care team, as I have outlined previously. We also do a handful of fetal referrals where we've actually brought pregnant women to Omaha to deliver here. And that is in conjunction with our OB and maternal fetal medicine colleagues at the University of Nebraska. And in some cases, those families have relocated to Omaha for delivery. So as I move into some of our medical review, I'd like to just remind everyone that as a neonatologist, I view everyone in the eyes as they're a premature or maybe full-term baby in the acute hospital setting, and sometimes don't realize or need to remind myself that babies eventually grow up. And this is the same baby from the slide before who's now going on 3, and I still think of her as an infant in our neonatal intensive care unit. And so a lot of the data I will review is related to in-hospital complications and discharge home. Number one, because I'm a neonatologist and that's where I focused a lot of my care, but also because that's where most of the research is right now. And there isn't a lot of long-term information out there yet. Before I go and delve into some of that stuff, I want to turn it over to Dr. Starr, who's going to talk a little bit about the genetics of trisomy and testing.
All right. Hi, everyone. I just want to take a brief moment to thank the organizers for having us, to thank Dr. John Carey for his amazing mentorship. I'm so fortunate to have gotten to work with him over the years. And then, of course, Dr. Birge. She's just doing amazing work. And this whole presentation is hers. I'm just kind of helping with about 2 minutes here. So I did want to bring up the genetics. So as one of the reasons that most of these patients get referred is because they do have a diagnosis of trisomy 13 or 18. Underlying that transfer for concerns of not the same care at their own institution. So from a genetics perspective, I'm usually involved with helping with the diagnostics for most of the local patients, of course, but also for those that come in. Most of them come in with a solid diagnosis. They have a fluorescent in situ hybridization study or something postnatal beyond the NIPT that confirms the diagnosis. Even an amniocentesis that is off of baby's fibroblasts. And so that's diagnostic. You don't really need to confirm that after delivery necessarily, but for the professionals on the call and for the families also, it's been interesting. They don't all come in with the same testing. And so we would anticipate that we would have, at least something from an amnio or postnatal from the fish perspective, but we always want to have a follow-up karyotype because remember that there can be translocations, there can be copy number variations with just large duplication on 13 or 18 that could give you a fish positive, but you would need that karyotype to really know what the diagnosis is that you're looking at. And then I do have permission to share this, but there was a patient once that was sent who had a diagnosis in the medical record of trisomy 18, but on looking more carefully, really there wasn't a clear genetic diagnosis of trisomy 18. And indeed, they were sent here with that assumption. And when we did further testing, baby actually had a different genetic condition where I think we were very capable of taking care of that baby as well, but quite a surprise to the family. So definitely always encourage your local professionals to make sure that you have the right diagnosis and then that's sorted out before transferring to another institution. Can cause a lot of confusion, but we do recommend something beyond non-invasive prenatal testing, not with trisomy 18 as much, but I have seen that incorrect a few times, mostly in the false negative category. But if you have a false negative on NIPT and you feel like baby just really looks like trisomy 18 or 13, still, of course, send studies to confirm. Okay, Nicole, next slide. Okay, and then another thing that I think has come up a lot over the past couple of years since we've seen so many more little ones with this condition in Omaha is there's this push for me often to look for mosaicism. And I don't necessarily have a problem for that. Of course, our curiosity it's interesting to see if other cell types, especially in a lot of the babies that we see, because many of them are doing really quite well. And so that question comes up, are not all of the cells impacted by the extra 13 or 18? And so indeed, we will look for mosaicism sometimes, but I don't personally recommend it under most circumstances. It really doesn't help us in the medical care of the individual. There's actually a few families that I can remember that really convinced me to look for mosaicism in a few different tissue types, since it was easily obtainable with procedures, because they were convinced, and I could understand their thought process, that mosaic was quite the buzzword for several healthcare providers in treating babies quite differently. I know most of us, we want to look at every baby, just, what are they showing us with their clinical presentation? What's their, their whole picture looks like. But if that word mosaic was there, they were fairly convinced that when they went to their home institution, that they would be treated very differently than if that term wasn't there. And so indeed, sometimes we would find mosaicism in patients, but even in a couple of the patients that were really among the greater number doing fairly well, we never did find mosaicism, and that was looking in even a few different tissue types. So of course, you can look at blood, you can look at fibroblasts from a buccal swab. I would never want baby to have a special biopsy to look, but if there is going to be a surgical procedure, and so you can easily get tissue from a different type, I would recommend trying to get something from a different embryonal line than, more ectoderm from a fibroblast cell, like trying to get something mesodermal or endodermal to look at. Another point I wanted to make from I am a clinical geneticist, but I also have training in clinical cytogenetics and genomics, is to remember that many times we think that FISH is the best way to look at a lot of cells really quickly, and so therefore a better way to look for mosaicism. But really, from a technical perspective, the way that the cultures work, chromosome and karyotype studies really are typically better for looking for low-level mosaicism. So just kind of keep that in mind and remember your goals, and always support the families in that, whether your child is really struggling or if they're doing quite well, looking for mosaicism is mostly for curiosity. It shouldn't change how we take care of them as a patient. Okay. And then next, just from the neoplasia perspective, this comes up a lot, whether to do screening and when. It seems so unfair to me to bring up neoplasia to these families that are always going through so much already, but we really need to, because if they do want to opt into screening, then some of these cases of Wilms and hepatoblastoma have actually happened very young. So in this is my favorite article describing it from Pharmacus, Barnes, Carey, and Braddock, which is a nice overview of why we screen, when we screen, how we screen, and what the levels of those malignancies are. And so they, at one point, something I found really interesting was they would wait until a later time to initiate the screening, but there's a comment in this article about how that's really probably not the best approach, because there have been even little newborns who have had these tumors come up. So it is a discussion, unfortunately, that you have to have fairly early in the disclosure. And so we do recommend starting with that baseline AFP level at birth so that you can monitor the trend. I know that it will be, of course, quite high, but especially in babies with trisomy 18, we know that watching that trend can be a little bit more complicated if you don't get that baseline from the beginning, because it seems they can be elevated for a while. So at least you can watch that trend coming down, hopefully. And then, of course, if you're going to screen, taking that screening seriously. If a family wants to spread it out, I think we can all understand that. Or if they opt out of the screening, that, of course, is their decision. But if they want optimal screening, it's really best to keep it at those time intervals, because those time intervals were made for going as long as you really safely could before another screen to optimize treatment. And so when you start spreading out to, well, we'll do it every 6 to 9 months or every year, I know we can all understand trying to keep that invasiveness to a minimum for these families, that they really are set up that way for a reason. And so if you start extending, you might miss some. All right, that's it for me. Thanks, guys.
Thank you, Dr. Starr. So as I mentioned before, since I'm a neonatologist, I'm going to start a little bit of the medical discussion about perinatal and neonatal considerations. And as Dr. Starr mentioned, most families will have a diagnosis or high suspicion of a diagnosis of trisomy. And hopefully at this time, the delivering team and the MFM and OBs have had a chance to talk to the parents about what this means. And as a neonatologist, you may be brought in for consultation as well. It's always important to have a plan prior to delivery, and actually well before delivery, because many of these mothers can develop complications that lead to preterm delivery. So plan together about who's going to be in the delivery room, what kind of resuscitation is planned. And then after the baby is brought to the NICU, for parents who are seeking interventions, we do a relatively thorough evaluation. Even if the baby's had a normal echo prenatally or normal ultrasound screenings, we will repeat those postnatally, because we have learned that the babies can have many anomalies that are just not able to be detected prenatally. And families have been surprised by new diagnoses like tracheoesophageal fistula, congenital heart defects. We've had some diagnoses of holoprosencephaly that were not known prenatally. And so in order to give the family the best prognostic information, we will do a full evaluation to make sure we really understand what's going on with each individual patient. I wanted to take a minute to talk very briefly about the mothers and babies who did deliver in Omaha. And it was a small group, 13 mothers over about the course of a year and a half who delivered in Omaha. They were a median age of 37 years. The first two women who delivered in Omaha had a diagnosis of preeclampsia that led to mildly preterm deliveries, and we were worried that this may be an unrecognized complication associated with a diagnosis of trisomy during pregnancy, but fortunately the remainder of the pregnancies did not have that complication. However, for a variety of reasons, the mothers did deliver a little bit early at a median age of 36 weeks, and their babies weighed just a little over 2 kilos. A little bit surprising, maybe, but an area for caution or further investigation is that we had a fair number of cesarean deliveries, particularly primary cesarean deliveries, which is higher than what we would like to see, higher than expected averages. A couple of those were repeat, and so that makes sense to me, but we did have several cases of fetal intolerance of labor, the 2 episodes of preeclampsia that I mentioned, and a couple of babies who presented in breech presentation that necessitated cesarean delivery. And this does incur additional risk to the mother, which is why it's important to have a delivery plan established between the OB team and the neonatology team before the moms actually present in labor. So some mothers may choose to undergo a cesarean delivery and some may not. So it's important to know the mother's wishes before that time arrives. Just to touch briefly on some of the neurologic issues we see, we know that in babies with trisomy 18 in particular, they have a higher incidence of cerebellar hypoplasia, agenesis of the corpus callosum, and about 5 to 25% of the babies have myelomeningocele, and we've repaired a fair number of those in Omaha. And then also in babies with trisomy 13, incidence of holoprosencephaly that's somewhere between 17 to 39% of the patients. And so these are reasons why we do not just screening head ultrasounds, but usually full brain MRIs and sometimes even of the spine if we have concerns, to make sure we really understand what's going on with each patient so we can better understand the wishes for the family with regards to treatment. Many patients will have seizures, not necessarily in the newborn or neonatal period, but even after hospital discharge from the NICU, as well as hypotonia that could interfere with their ability to feed. And so it's important for us to anticipate and diagnose some of these issues so that we can offer the best plan possible for these babies. Sometimes parents will come in and ask, what does this mean for my baby if they've been diagnosed with trisomy 13 and 18, and what does that mean for their long-term development? We do know that most patients will have fairly significant developmental delay, that the hypotonia we see in the NICU changes to hypertonia later on. And although many are unable to ambulate independently, they can achieve a fairly good degree of mobility, either with a walker or other assistive devices. And I think there's a talk later in the week about that specifically. And even though expressive language isn't usually fully achieved, communication occurs very regularly between family members and their children with words, signs, hand gestures, and that sort of thing. And I think we have a tendency to focus as providers about things that the patients or babies will not be able to do. But there are a lot of things that they can do. And I think that's important to provide parents with both that information to say, even though they may not be able to walk independently, they may be able to ambulate with a walker and get better ideas for communication and talk to other families about how they communicate with their children who have trisomy so that our parents in consultation know what they can expect. Because we know that they are high risk for developmental delay, we engage early on our speech therapy, physical and occupational therapy teams as well, while they're still in the NICU, well before hospital discharge. And I've listed here or shown pictures of two of our former patients who are doing some independent play, and engaging those teams early and getting patients rolled into early intervention and special education programs that will meet the needs of the individual patient and their family are very important. We anticipate many, if not all of these children will be able to attend preschool. And so we want to make sure that they are as ready as they can be. I have also thrown in a couple of pictures just to liven things up a little bit of a couple of our former patients who are in close contact, but shows the progression that they have made. The photo on the left is them at their 1-year birthday, and the photo of them on the right is at their 2-year birthday. And just the expressiveness and how they're playing with their toys and the progress that they have made in that 1 short year is really quite remarkable. Also concerning to me as a neonatologist is adequate weight gain after delivery, because I know that the bigger I can get my patient, the less complicated their surgical course would be theoretically. And so we want to make sure that we are providing optimal nutrition for our infants who have trisomy 13 and 18. And because dysphagia is very common, we will frequently have our occupational therapist and speech therapy team evaluate babies to determine how safely they can orally feed and whether or not there's aspiration. And we also have a dietitian who follows their caloric needs very closely. Many families will opt to provide some type of nutrition either by the form of NG tube versus a G tube. And so making sure that they understand the goals of what each of those tubes provides and making sure it's in alignment with what the family wants. But that's something that we commonly see in our patient population as well. One thing that it can be frustrating is making sure that when we monitor growth within the ICU is that we're using the right growth curve. And it's even an issue in our institution where in our electronic medical record, we don't have access to the trisomy 18 growth chart, for example. So that's what I have listed on the right. And as you can see, it's very different than your standard CDC growth curve. And making sure that we're following the right growth curve will really help in ensuring that these babies are getting the right calories and doing what they need to do from a nutritional perspective. This is an example of a patient that we took care of for cardiac surgery who was cared for at another institution. And so the growth with these little kind of stars reflects what was going on prior to their arrival in Omaha. And you can see a couple of spikes here where we thought we were doing really great with nutrition, but when I looked back to see what was going on during these periods of rapid weight gain, it was actually secondary to fluid overload, post-op from cardiac surgery, and then the baby went on to have sepsis. And so nutrition after they recovered from their illness and good weight gain did eventually improve. But again, it's not appropriate to have them and follow this trajectory on your standard growth curve. I wanted to spend some time talking about cardiac surgery, just because, as you saw earlier, this reflects the majority of referrals to our program. And so talk a little bit about timing of surgical intervention and how we can best determine the right time, the right weight, and monitor for complications that could potentially occur after babies with trisomy 13 and 18 undergo cardiac disease. We know that heart lesions are present in the majority of babies who have trisomy 13 or 18. Most commonly seen are patent ductus arteriosus, ASD and VSD, although tetralogy and coarctation and valve issues are also relatively common. When we review a large surgical database between 2004 and 2015, however, we saw that cardiac surgery was performed in about 7% of all patients that had trisomy 13 or 18. So even though these babies have cardiac disease, the surgery is performed in just a small minority of patients. There are a lot of things that we take into consideration when we offer surgical intervention. So I'm going to go through these hopefully relatively quickly. In determining whether the timing of repair, we know that weight does matter. And this has been looked at even in children without a genetic syndrome, that if you're less than 2.5 kilos at the time of surgery, you have increased mortality. And this is regardless of how complex the surgery is. And in particular, with babies who have trisomy, weight is a very important risk factor for a positive outcome. And this is regardless of the type of procedure performed. So whether it's corrective or palliative, that generally 3 kilos tends to be the age amongst across institutions at which babies will be considered for surgical intervention, just based on what we know in terms of risks and outcomes. So if weight matters, it makes sense to say that age should probably matter too. Again, when we look at babies without genetic syndromes, that there is a higher mortality rate and complication rate if surgery is done at less than 30 days of life. When we look specifically at babies who have trisomy 13 and 18, we have seen that when you're older at the time of surgery, you tend to have better long-term survival. But that was comparing surgery at 1 week versus delaying it to somewhere between 6 and 17 weeks. What we don't know is that the babies who did better were more stable, quote unquote, prior to cardiac surgery. And were maybe even discharged home prior to cardiac repair. And so that, I think, question still has a little bit left to be answered, but at least in general, we say that a little bit older age and a little bit higher weight does tend to improve your post-operative outcomes. So because of that, this is important, at least in terms of clinical practice, that where you can, ongoing discussions should occur with your OB team about avoiding preterm delivery, which as a neonatologist, I know is a lot easier said than done, because sometimes there are complications that occur during the pregnancy that mean the baby has to be delivered early. But knowing that earlier delivery, which could relate to a lower birth weight, may not result in improved outcomes for the baby. That's important information that our OB and MFM colleagues need to know. I wanted to talk a bit about surgical complexity and how this relates to outcomes. As I mentioned before, the majority of patients with trisomy have cardiac lesions that are either PDA, ASD, or VSD. And these are generally considered to be low-risk procedures. However, when we look at large databases of babies who undergo surgery for these cardiac lesions, we see that the mortality either during the procedure or prior to hospital discharge were significantly higher than in patients without trisomy. And so I just wanted to briefly look into that a little bit and review some of that data with you. So many hospitals report to the STS database, which gathers information on all the cardiac surgeries in multiple hospitals throughout the country. And they have actually categorized surgeries based on their risk. And so most patients who, undergo repair are generally in the stat 1 or stat 2 category. And that would reflect your PDAs, your ASDs, and your VSDs. It's rare that patients with trisomy are undergoing stat category 4 or 5 types of procedures. So generally, you're looking at low risk, uncomplicated procedures. This is a chart that gives us a little bit more demographic information of patients who undergo cardiac surgery with trisomy 13 and 18. And as you can see, they're generally between 3 and 4 months of age. And a good portion of them were born prematurely with a birth weight around or just above 2 kilos. But during the interval period of time, they have gained weight and now are around 3.5 to 4 kilos. These are the most common diagnoses that were submitted to the database. So overwhelmingly, VSD was the most commonly seen. That was followed by tetralogy of Fallot and then PDA. And this graph kind of summarizes all of the patients with trisomy who underwent cardiac surgery for that 7-year time frame. And again, this is 125 hospitals, 304 patients with either trisomy 13 or 18. You can see over the course of several years, the number of patients undergoing surgery has increased. And that's reflected by the vertical graphs there with the trisomy 13 babies in red, trisomy 18 babies in blue, and then those numbers combined are the gray lines. The mortality, moving from left to right every year, is also divided based on genetic diagnosis. And the concerning trend that was seen in this study is that even for low risk and simple procedures, the rates of mortality were higher compared to the baseline STS data or group that's here in the green line. And so even for simple procedures, patients with trisomy 13 and 18 had a higher rate of mortality. And that is depicted differently here in this table where it's listed out with regards to stat procedure. And you can see, particularly for some reason in babies who have trisomy 18, their risk of mortality was significantly higher compared to the overall patient population. And that was something like 10 to 20 times higher, depending on the stat category. So significant increase in mortality, even for what we would consider to be low risk surgeries for babies who have trisomy. In addition, post-operative complications were significantly higher in babies who have trisomy 13 and 18. In particular, cardiac arrest was significantly higher. And so despite these numbers, there was an overall 80% survival to hospital discharge. So I think when we're talking to families and evaluating surgical candidacy, it's important to note that even low risk procedure carries significant risk for patients with trisomy. But if they can make it through, there is a pretty good survival to hospital discharge. However, complications may lead to a longer hospital stay. And so it's important to assess each patient individually and to have group consensus amongst your cardiac and surgical teams before offering surgical intervention, making sure you have a candid discussion with the family about whether or not we think that their baby would be a good candidate or not a good candidate based on some of these risk factors. We've also looked at whether pulmonary or airway complications after cardiac surgery, what is that like in babies who have trisomy 13 or 18? And so this was a study that looked over a 10-year time frame, babies who underwent cardiac surgery. So of the patients with trisomy 13 or 18, there were 14 of those who underwent cardiac surgery, and they were compared to 42 controls, and they were matched by type of cardiac surgery. And they were followed post-operatively until discharge, looking specifically for airway and pulmonary complications. And those were described as prolonged mechanical ventilation for greater than 7 days, need for reintubation within 72 hours, need for tracheostomy or having a new diagnosis of tracheitis. So those were considered to be complications. And if you look at the graph in the middle, the patients with trisomy 13 and 18 had a significantly higher percentage of complications compared to the patients who didn't. And in particular, the need for mechanical ventilation, the number of days post-operatively was significantly longer in babies who had trisomy 13 and 18. So they had a more complicated respiratory course with longer hospitalization. However, 93% still survived to hospital discharge. So I think it's important to take all of these factors into consideration when we're looking at whether or not someone would be a good candidate for cardiac surgery. One other comment that I would like to make is regarding pulmonary hypertension and the frequency with which we see it. And we have looked at babies referred to our facility who underwent heart cath to assess for hemodynamics. 26 patients actually had heart cath and 24 underwent cardiac repair. 2 of them had elevated pulmonary vascular resistance that we deemed was too high for them to undergo surgery successfully. And so they were deemed to be not candidates. But a significant portion, or almost 80% of the babies, had evidence of pulmonary hypertension before surgery. And so that was pretty significant. And even with intervention, there were still 58% of babies that had pulmonary hypertension after surgery. When we broke down the types of cardiac lesions into restricted versus unrestricted pulmonary blood flow, we see that the babies with unrestricted pulmonary blood flow, so again, PDAs, VSDs, and ASDs, there was a significant portion who were discharged with targeted pH therapy after cardiac repair and required more invasive ventilation afterwards. And so we know that clinically significant pulmonary hypertension is present. And if you have a lot of unrestricted pulmonary blood flow, you may require prolonged treatment with targeted pH therapy or even mechanical ventilation. We were able to monitor these patients, and we have learned that pulmonary hypertension develops rapidly and can be quite severe. And so this is a criteria that we look at very closely when we are determining surgical candidacy. That has led us to operate a little bit sooner than what we would deem would be kind of a standard time frame. So for a VSD, for example, instead of waiting 4 to 6 to 8 months for the babies to develop over circulation and congestive heart failure, we're repairing those at 1 to 2 months instead before the babies can develop severe pulmonary hypertension. And then we have a lot of medical management as well that we use that most other places, I think, have integrated into their treatment of pulmonary hypertension. But just to optimize our results, these are some of the other things that we evaluate for. I wanted to briefly also make a few comments about ECMO because that kind of goes in line with offering cardiac surgery. And we reviewed the ELSO database of all patients who underwent ECMO, and 28 patients out of 46, almost 47,000 underwent ECMO during this 18-year timeframe from 2000 to 2018. So a very, very small number. But when we look at the rates of in-hospital mortality, which is how the database reviewed this data and analyzed the data, the survival rates for patients with trisomy 13 and 18 falls into what they would consider to be the expected ranges of survival after ECMO. And so that's something to consider if you're offering surgical intervention, or when a patient comes here for surgical intervention, that ECMO probably provides a similar rate of survival, not necessarily an advantage. And so that's something also to think about. This is an interesting survey that was done internationally of surgeons and intensivists, asking whether or not they think ECMO should be offered in a variety of clinical scenarios. And on the left-hand side, clinical scenario number 4 is a patient with trisomy 18 who presents with ARDS. And the majority of physicians who are surveyed said that they didn't think ECMO should be offered. But when they, the researchers divided it out amongst surgical and medical subspecialists, there was a pretty big difference in response rates. And the group that said ECMO should be offered most was the pediatric cardiothoracic surgeon. And that was significantly higher than the pediatric critical care physicians, neonatologists, and pediatric surgeons. And so I think it's interesting to see that the CT surgeons have a different perspective than the rest of the care team. And we have seen that difference here in Omaha as well. We ended up have placed 4 of our patients with trisomy 13 and 18 on ECMO. Most of them had some form of VSD, with the exception of one that had a balanced AV canal with a coarctation. And many of them were cannulated post cardiac surgery. They were about 2.5 kilos and a day of life 67, so about 2 months old, had relatively short ECMO runs. And our survival to discharge was about 50%, which is very similar to the reports from the ELSO database. And so in order to be a little bit more thoughtful about how we offer ECMO and whether a patient would be a candidate, we actually have ECMO candidacy meetings now for all patients who are at risk. And that includes a multidisciplinary team of surgeons and specialists and intensivists. And instead of waiting until a code event or something catastrophic happens, we have a discussion ahead of time to say, if this complication were to arise, would this patient be a candidate for ECMO? And that allows us to have very transparent discussions with our families about ECMO candidacy and expectations pre and post operatively. And then for the patients that we do cannulate, we have weekly team meetings where we review goals and discuss complications as well. And that's worked out well for us. Moving away a little bit from the cardiac perspective into respiratory and ENT, we know that cleft lip and palate are common in patients with trisomy 13. Upper airway obstruction and aspiration can also be seen quite commonly. And this, from a study, the same study earlier that looked at airway and pulmonary complications, shows that post-operatively, many of the patients with trisomy who had cardiac surgery eventually received a designation of critical airway, meaning it was very difficult to intubate those patients and tended to have a longer duration of mechanical ventilation, and at some point underwent airway evaluation via bronchoscopy. And so this just supports the fact that many of these patients will have airway or pulmonology issues that require a little bit more care and management post-operatively, and to expect some of those when you're caring for patients. Because of that, we engage our ENT and pulmonary colleagues very early. These are two of our patients who went on to require tracheostomy prior to hospital discharge. And then we know that even after they leave the NICU, repair of cleft lip and palate, need for tympanostomy tubes are very common as well. And so making sure that they have a dedicated ENT and or plastics or craniofacial team that can help address the cleft issue as well is very important for care after hospital discharge. I wanted to talk a little bit about tracheostomy placement, and if you haven't engaged the palliative care team prior to a trach discussion with the family, this is a really good time to engage them, because it helps you really narrow down family goals and values when trying to decide treatments that would be appropriate for each baby. And there are a lot of items that we have to consider when we're discussing a trach with a family, including, how will this impact the baby's survival? Does the trach foster the family's definition of a quality of life? And how will having advanced technology like a trach and event in place impact the baby's ability from living at home with a family? And would they be required to receive skilled nursing at a facility that's not at home? ICU physicians were actually interviewed and asked, well, if you have a big decision that like a trach that needs to be made, how do you approach the family, and how do you go about making this recommendation to the family? The vast majority of respondents, so this is NICU and PICU physicians, so that they would organize a meeting of the medical team and seek out people who are unable to attend and come to a consensus, and then make that recommendation to the family. But a fair amount of people also chose the last option, which was informing the family about the available options and letting the family decide what action to take. And so I think there's still some variability about how physicians approach the topic of something like tracheostomy with families. And I think it's important that we get as many people involved as we can to help make sure that the recommendations we have and the decisions that the family makes are actually in line with their goals for their children. There's also been a lot of discussion about how we can, as physicians, can optimize care of some of these infants who I would consider to be chronically critically ill, at least through the first several months or year of life after they received cardiac intervention. And one of the number one things that we have realized is that involving other care teams is very important, as well as continuity. And we try to do that pretty significantly as much as we can with our nursing staff. But getting a primary attending to manage the care of these patients is also very important. And then frequent communication with families, I know seems like a no-brainer, but it probably doesn't happen as often as it should. And sometimes setting up a designated day or time of the week to meet with families to review goals and care are actually really important to foster some of those decisions. Our group in Omaha has made a list as well of things to consider when you're looking at decision making, because we know each family is different. We know that each family makes decisions differently, and there are a lot of things to consider when we're talking about things like tracheostomy or cardiac surgery or some other type of intervention, and making sure that all of these are in the forefront of our mind when we're engaging with families and making the medical plan. It takes more than just one person and one parent to kind of come together and make a decision, and that approaching this from all aspects, I think, will result in the best outcome for both the family as well as their child. We actually decided to put more of this into context by interviewing families to get their perspective on communication. And we specifically interviewed families who came to Omaha for cardiac surgery after they were denied care at their local hospital, specifically because their baby had trisomy. And they were asked a series of questions. Some of them are yes or no, and some of them are open-ended. And so I thought this would be a nice way to wrap up the talk and to say, if you're our medical team and you're wondering how you can best communicate with parents who have trisomy, this is a really good list and some really nice exemplary quotes from families on how to best communicate. And the theme that we recognized very consistently was how important it was that we as a medical care team honor the child's intrinsic worth, and that they have a place in their family, that they are valued members of their family, and to recognize that. And I think sometimes we don't do that enough. One quote that I felt was particularly important is when a parent said their worth is not measured by the degree of their medical challenges nor their assumed potentials, but by the breath of life breathed in them. Families also thought it was really important to offer personalized approach to care, instead of saying babies with trisomy always do this or never do that. Really recognizing that each baby with trisomy in each family is unique, and that we need to really address them as such. Families also said that they wanted professionals to be courageous and recognize that there are shifts in outcomes, and consider that this is reflecting an evolving paradigm, and how we can look beyond textbooks into the actual child. And then finally, fostering collaborative communication. And there are certain terms that I think will kind of cut off communication immediately with families, and using terms like universally lethal or saying your baby has a 0% chance of doing something really puts up a wall between the medical team and the family. And so we have to find ways to have open dialogue and be transparent with families when we're communicating with them about their baby. Here I've highlighted just 4 of our recent Omaha graduates. I took care of all of them when they were babies, and now, as you can see, they're toddlers and doing things like riding horses and playing independently with their toys. And I think this is a good reminder that regardless of how bad or complicated things can get in the NICU, and it can be a very scary time, we have had great success in getting these 4 children home with their families, who are very much loved and very much a part of their family and very much cherished. And so we honor the time that they spent with us and are happy that we could provide care for them so that they could go home and live their lives with their families. And at that, I will just put up my references very quickly, but maybe I'll just leave up the slide of these children because they're so cute, and then we can open it up for questions.
Well, Dr. Birge, that was an incredibly comprehensive, more than a thorough walkthrough. And I have to say that the last paper you cited that you and Dr. Weaver did, I found to be really historically different than anything else I had seen written, particularly this idea of honoring worth. I don't want to take up our time for questions, have other people ask questions, but that idea, the challenge of people feeling like, this was declined, or they wouldn't operate on my child, or they wouldn't do this. I think so much of it is that, that we don't generate the message of worth. And so maybe the language surrounding that is something we can all work on. But I don't want to take up our time because your presentation, I did want to try to see if we can get through the questions, but we only have a few minutes. There is a question that I would like to hear your thoughts on as well, by Emily Morris. It said, what are some of the immediate medical exclusionary criteria for referral? And I assume that's like referral to Omaha from another place.
Most of those are cardiac in nature. So babies with single ventricle physiology, we tend to exclude because the risk, even without a genetic diagnosis, is very high. And most of those patients need recurrent procedures. And so it's hard to try to coordinate that with your surgical team in Omaha, with your home team elsewhere. And so generally patients with single ventricle physiology are excluded, and those with significant pulmonary hypertension based on CAF data. And so our PH team has a cutoff for PVR in terms of Woods units, and I think it's 8, but don't quote me on that. But they have like a cutoff too, in terms of, is the pulmonary hypertension too severe? We tend to exclude based on, those are probably the two main reasons why we exclude patients from a medical perspective. We're a little bit torn in terms of babies who were born prematurely and have significant lung disease, because we know that lung disease associated with prematurity can have an additional impact on your ability to recover from cardiac surgery post-operatively. And we've had some mixed success in terms of getting babies on a home ventilator or that sort of thing. And so if they have severe BPD, that's something that we kind of take on a case-to-case basis. Some of the kind of non-medical issues or social issues that we look at is whether or not the family, has a plan for who comes to Omaha, who's going to care for the patient in Omaha. Are there other family members back home that need to be cared for, and can they manage to figure out who's going to be where and how they can keep the rest of their family afloat? Because like I said earlier, we've had parents become homeless and unemployed with no transportation or no health insurance or no way to actually care for their children after they receive treatment at Omaha. So we want to make sure a lot of that has been vetted before they make the transfer here, because obviously we want them to go home and be healthy and successful, and we can't do that if they don't have a home to go to. One other thing is that we ask that some families can at least state what their goals are before coming to Omaha, and have an ability to recognize that there may be times when there's nothing we can offer, that there may not be an appropriate intervention, whether it's medical or surgical for their child, and making sure that families recognize that coming to Omaha doesn't mean you're guaranteed that survival and guaranteed no complications. And we have had some issues with families who are unable to recognize that, and so for that reason they have been declined as well.
Thank you. Do you have diagnoses that if someone contacts you because of, let's say, cardiac issues, but the diagnosis is not trisomy 18 or 13, but another uncommon chromosome disorder or single gene disorder, are you at this point taking those calls and seeing how it goes, or
We've had a couple of babies with Pallister-Killian syndrome, and then the patient that Dr. Starr mentioned earlier, we have brought to Omaha as well. And so it's not just trisomy or no trisomy, but we've seen a lot of other patients with other complex genetic conditions. And so there isn't necessarily an exclusion just based on the genetic diagnosis.
Right, thank you. We have like 1 minute left, and in the chat there are 3 highly complimentary comments. Renee Bradley, that was amazing. Someone else, parent perspective, this is gold. Maureen Boshin, one of my genetics colleagues, outstanding, thank you. There was one question here, I think we probably have to close with this, that I thought was interesting about whether or not over the years you think our textbooks in medicine have been kind of changing and keeping up with the times and what we learn about in terms of trisomy 18 and 13. What do you think?
I can offer my opinion. I love to hear Dr. Starr's opinion as well. And I think some of the, in terms of like medical textbooks, I think that, yeah, they need to catch up with what we're seeing. And the hard part is like the slide I showed where we had 50 or 70 referrals in 1 year for surgery. It's hard for us to analyze what's happened and disseminate those results fast enough. And so the information that we can get out to other physicians and families lags a significant period of time because it just takes that long to disseminate information. But yeah, I think there's a lot of catching up that needs to be done in terms of education for families and parents with a diagnosis and education of all healthcare providers as well. Dr. Starr, what do you think?
Well, we're fixing it locally because we don't use a lot of textbooks anymore in medical education. And the students mostly hear from clinical professionals and we give them, our slides and references. And so it'll depend on who's giving those genetics lectures in those local institutions, in my opinion. John, I'm curious what you think.
One thing that we've talked about that I've wanted to do was to actually bring people like both of you and others together into an hour-and-a-half webinar that we would provide to all directors of genetics courses. And so that in fact, all of them would have this option to hear. Now we, whether it be a live Zoom like this or whether it be a tape lecture. But in the interest of time, one more question also from Dr. Boshin. You might know this, Nicole, as well. How often does insurance reject transfer treatment because of the diagnosis of trisomy?
That actually happens relatively rarely. Usually if we can prove that we are offering a treatment that is not being offered locally, we can get it covered. It takes a while. And so that is usually the problem that we run into, is that most people know the insurance world, I think, operates at a different rate than everybody else. But through some practice and I guess just repetition, our case management team and care coordination team has developed a pretty efficient process, and it's pretty rare that the patient doesn't come because of insurance denial. We are generally able to get that covered.
Yeah. The one child that we transferred from Primary Children's almost 2 years ago now, we also found exactly right that your team plus the insurance company here actually worked that out well. I think we're going to have to finish up because we're actually more than 5 minutes past the hour. I think there were some comments I didn't get to at the end. I apologize for that, but I deeply appreciate the scholarship involved in your talks, and thank you so much. And it'll be hard for me not to think that you're not going to be invited to speak at a soft conference when we're back in person in the future.
That would be great.
So do you have any other comments, Terry or Kelly?
No, I think we covered everything, and I would just like to thank you both again. I'm sure Terry and I are both getting messages right now from families just expressing their gratitude for your talk and for everything that you covered today, and just their appreciation of the program that is going on in Omaha. So thank you again for presenting and sharing with us.
Thanks so much for having us.